prepared for surgery before. So she comes in, she's otherwise well. When they do the labs, every other lab is okay except 2 labs. Her sodium is at 159, up 143 from the last time she was here for planning of surgery. And the other lab that is significantly high is calcium, which is at 4.04 millimoles per liter. So these are both raised. So surgery is cancelled and the patient is referred for hypernatremia workup. So we basically ask, what is going on with the patient. We know that she has got gallstones. She's here for open cholecystectomy. She's got pre-op hypernatremia and hypercalcemia. So when we ask why the patient might be, what's going on with the patient, take a bit of history. She admits that she has had recent polydipsia, polyuria over the last about 6 months or so. Maybe a bit of cough. So I mean that is a bit of cough that especially is annoying in the evenings, but there are no other symptoms. She has not lost weight, no fevers, nothing else. Her bones don't hurt, really nothing else. She's otherwise well apart from that abdominal pain, a bit of cough, especially in the evenings. She's dry to the most part, and she's got a polydipsia, polyuria. So, medication assessment as well. Really, she's not taking any medications, not chronic, not recent. And on physical, she's grossly okay. She's fully conscious. Her blood pressure is slightly raised at 148/92, which you think is maybe because she's just annoyed from having, had her surgery cancelled. And when we do an orthostatic BP, there's a systolic drop of 30 millimeters of mercury. So I'm just going to call on Dr. Preach at this point. Dr. Preach, why do you think this young lady might be having hypernatremia?
Thank you, Dr. Erasmus. So from your history and what you have presented, there are a number of causes that can be causing the hypernatremia. The first one, probably the polydipsia and polyuria is causing an osmotic diuresis, and this could cause free water loss, causing the hypernatremia. So that is one possibility. The other possibility, the patient has a hypercalcemia. Hypercalcemia interferes with the urine concentrating ability, and therefore there's also a subsequent net water loss that can also cause hypernatremia in her. I see she has a orthostatic BP drop, so probably I'll need more information from that to answer. However, also with a history of gallstones cholecystitis, if she had increased insensible water losses with inadequate oral intake, that in itself could also cause hyponatremia. Thank you.
Yeah, thank you very much. I mean, you nailed it here. I mean, we're thinking the same things. This lady basically has a few things already in her history which are guiding us towards a potential reason as to why she's hypernatremic. One, she's probably losing quite a bit. That polydipsia, polyuria, we need to evaluate a bit more. She's got hypercalcemia, which definitely can interfere. So I'll just give a bit of, I'll probably let Dr. Preach eventually expound on some of these details. The orthostatic drops here, we thought are just because she's probably hypovolemic. She just came from home, and she was ready for surgery, and now she's in her room. We go check, and she has this BP drop. So we think maybe she's not been drinking, waiting for surgery, and maybe that's why she has got the orthostatic changes. So I would like to stop here briefly, and then have Dr. Preach take us through the next talk of the day, which is the pathophysiological approach to diagnostics, and then we shall pick up from there just to see what else could have applied to our patient diagnosis. Thank you. Dr. Preach, over to you. I'm going to...
Dr. Rasmus, before we go to Dr. Preach, I'm going to load some few poll questions regarding pathophysiology, and then we get the audience's opinion, and then we shall proceed to Dr. Preach. So here is the first poll.
Dr. Cornelius, sorry, I missed you there briefly.
Yeah, I'm launching a poll, and this is about what is the leading cause of hypernatremia in the ICU. We shall take about a minute. You should all be able to see this. Please respond. Hopefully, Dr. Preach will also respond to the first poll question we had regarding hypernatremia being more water loss than sodium homeostasis disorder. I think in the meantime, Dr. Preach can prepare to his slides for sharing. So I'll end the poll now. These are the results. So 59% said it's dehydration, while 37% said saline infusions, and then DI in 4% of the people responding. The third poll is here. It will also take us a minute. So what is the implication of hypernatremia in critically ill patients? So you can respond, and shall take about a minute still before we jump into the presentation by Dr. Preach. Okay, I'll end the poll now, and then I will share the results. So the results regarding the question of the implication of hypernatremia in critically ill patients, 58% said all the above. So increased mortality, delirium, and prolonged ICU stay. And then about 23%, which was the next value, said it's delirium. So with that, I will hand over to Dr. Preach to proceed with the next presentation.
Thank you very much, Dr. Cornelius. I hope I'm audible to everybody. So today I'll be taking you through the pathophysiological approach to the diagnosis of hypernatremia. We might delve deep into some animal pictures, but it's okay. I hope you get to understand what I'm trying to say. So just for purposes of definition, hypernatremia is the presence of a serum sodium more than 145 millimoles per liter, and this essentially makes you hypertonic. So unlike hyponatremia, hypernatremia is a hypertonic state. Now, classification, it's important for you to understand the classification. We have mild, moderate, and severe hypernatremia. And depending on this amount of serum sodium, people have symptoms. And it is important to mention at this stage, majority of the symptoms are in the brain, as I will show you in the next few slides. So having understood the definition of hypernatremia and the different classifications of hypernatremia, I want to take you through the pathophysiology of osmotic regulation. And then if we understand that, then we can go further to the diagnostic approach. So this is a diagram of a brain of a mouse. So please don't worry, but it's a mammalian mouse, therefore it represents humans also. Now, if I can just take you through this diagram, it is basically showing osmoregulatory centers. So I want you to, I'll take you through it. So this is the suprachiasmatic nucleus. This is the paraventricular nucleus. In this nuclei, we have the macrocellular cells. These ones secrete and they synthesize and make vasopressin, which is taken to the posterior pituitary gland. Here we have the OVL. It's called it has actually a very long name, OVL, and then here the subphonical nucleus, and then here the area posttrema. And importantly for you to note is that the the purple part is the ventricles. So right from the start, I want us to remember that the brain osmoregulatory areas are paraventricular, and they're represented by this yellow color. They're paraventricular simply because at the paraventricular area, we don't have the blood-brain barrier, and therefore the tonicity of the cerebral spinal fluid, which is the same as one in serum, interacts with the brain, and therefore they interact. Here we have higher centers such as the anterior cingulate gyrus and the insula. These are cortical areas that are actually involved in the affective action of someone going to drink water in case they are thirsty. Now, I need to mention that the normal osmolality is between 280 to 295 millimosmoles per kilogram. And once the serum osmolality is above 10 of this, once the serum osmolality is 10 milliosmoles per kilogram above the set point, vasopressin is produced from the posterior pituitary, and it goes and interacts with the kidney. And once it interacts with the kidney, it causes water retention in the body through a mechanism which I'll show you. Important to note, in case you are very hypovolemic, your tonicity also increases, and the kidneys are activated through the sympathetic ganglia. This is ventrolateral medulla. They're activated, and it also causes water retention through the aldosterone pathway. So we shall come back to this diagram. Next, which is very important for us to remember, is this diagram here, the blood-brain barrier. I want you to remember that the blood-brain barrier does not allow anything to pass through in the normal state unless there is water. And that's why in the management of hyponatremia, as my colleague will mention, it is very important for you to be very careful with how you treat someone, because it is these aquaporins that will actually cause water to either move away from the brain, as in the case of hyponatremia, or move towards the brain, as in the case of hyponatremia. Now, something also important to mention is that in the pathophysiological approach to these patients is that hyponatremia, you need to be very careful to know whether it is chronic or acute, for a very simple reason in the management, as my colleague will mention. However, important to note is that if you have chronic hyponatremia, these astrocytes, these food processes, what they will do, they will end up getting osmotic molecules from the brain, and they will increase their tonicity, and they prevent excessive shifts of water. So now, approach to diagnosis. It's very important we think through the history, physical exam, and then laboratory and investigation. So the history and physical exam can tell you a number of things. So what I'll do, I'll tell you the different differentials you can get from the history and physical exam. And for the laboratory investigations, I'll strictly stick to the urine tests, which will help guide you through this case. So we can have hyponatremia from a net water loss. And these are usually could be due to renal losses, for example, central diabetes insipidus or nephrogenic diabetes insipidus. You can also have renal losses, for example, from loop and diuretics and osmotic diuretics. Now, central diabetes insipidus and nephrogenic diabetes insipidus are usually due to the absence of vasopressin or the non-reactivity of vasopressin. In this diagram here, you can see when vasopressin interacts with the vasopressin receptor, it undergoes a number of changes, and later they cause aquaporin to come to the collecting duct. And it is this aquaporin that pulls water away from the collecting duct and back into the body system. If you have central diabetes insipidus and nephrogenic diabetes insipidus, there's an absence of vasopressin either at this level or at a higher level, and it causes you to be unable to activate aquaporins, and therefore the collecting lumen remains with water and you lose it in urine. So this is hyponatremia from net water losses. Similarly, from loop diuretic and osmotic diuretics. The loop diuretics act at the thick ascending loop of Henle. They inhibit the sodium potassium and the 2-chloride channel, and therefore they just cause a net water loss. The osmotic diuretics, similar manner, they just cause continuous water loss. So that's the first example of hyponatremia from net water loss. Could be just purely renal water loss. The second one could be non-renal water loss, whereby you have hypodepsia. Now, having said hypodepsia, it means you are unable to sense your ability, you are unable to sense that your serum is hypertonic. Now, hypodepsia, I'll take you to the original diagram. If someone has head injury and you injure any of these paraventricular areas, for example, OVLT, posterior pituitary, subphonical nucleus, and area postrema, if you injure any of these areas, you can have an inability to sense that the body has been, there is increased tonicity in the body, and therefore you get hypodepsia. So that is what hypodepsia happens. Then we have insensible losses from the respiratory system, for example, intercypnia, cutaneous losses such as sweating and burns, and gastrointestinal osmotic diarrhea. Now, it's very important. It's not only any type of diarrhea, but it should be osmotic diarrhea. And this diagram from this paper clearly demonstrates it. So if you have osmotic diarrhea, what it means basically, the contents in the colon are they are hypertonic compared to the surrounding. Therefore, they pull water to itself, and you end up losing more of free water. And usually, the concentration of sodium, the osmolarity is usually less than 100 milliosmoles. The stool is usually less than 100 milliosmol. In contrast, if you have secretory diarrhea can happen due to some toxins, for example, Shiga toxin and the cholera toxin. You basically lose, you could say, isotonic amount, isotonic fecal matter, meaning the serum and the fecal matter amount of sodium is equal. And therefore, ideally, since you're losing it, you end up with a net loss of sodium, and therefore you end up with hyponatremia with even hypovolemia. So it's very important to be very specific about the type of gastrointestinal losses that causes hyponatremia, that is osmotic diarrhea. So that's the first cause, hyponatremia from net water loss. So you can also have hyponatremia from hypertonic sodium gain. That's very important. For example, sodium bicarbonate infusions, these ones normally have a lot of sodium. For example, from feeding, this is very important, especially in children. Some formula feeds initially were associated with hyponatremia. Oral salt intake, this one can happen even in people who are suicidal. I was reading and I was really surprised that in suicidal people, they can take salt. So yeah, salt intake, but also it can happen in children, especially the toddlers, in case they find salt and they can take it. Then we have hypertonic enemas, hypertonic dialysis, primary hyperaldosteronism, and Cushing syndrome. So I just had a good picture of hyperaldosteronism to show you just how you can end up having hypertonic gain of sodium. So this is a healthy person, but in someone in aldosteronism, ideally what you have is that not only do you have aldosterone, but you have increased aldosterone. Primary, it basically means the problem is with the adrenal medulla. Secondary, it means could be other things. So you have a problem with the adrenals and they cause increased aldosterone, could be a tumor, and you have sodium retention. So again, it comes back to the hypertonic gain. You have sodium retention, and then you can even have volume overload. Now, having said that, the next thing I'll go is to the laboratory approach to the diagnosis of hyponatremia. So it's important to measure urine osmolality. So if someone is hyponatremic, you could go ahead and measure urine osmolality. So hyponatremia with low urine osmolality. Now, so if the urine osmolality is less than 300 milliosmoles per kilogram or less than that of plasma, this usually suggests central or nephrogenic diabetes insipidus. Remember, we mentioned vasopressin is very important in making you get get water back into the circulatory system. But if you have either of these, you have osmolality that is less than that of sodium. So it is hypernatremia with low urine osmolality. Now, it's important to remember that desmopressin acetate is used to differentiate between central and nephrogenic diabetes insipidus. Now, desmopressin acetate is basically an agonist of the vasopressin receptor, and therefore it will act like vasopressin and activate this whole system, and you get water back into the circulatory system, and you reduce your hypernatremia. Now, if someone has central diabetes insipidus and you give them desmopressin acetate, what will happen is that they will later produce urine that is actually concentrated. Okay, so that is how you will know that this person had central diabetes insipidus, and therefore they have responded to desmopressin acetate. If someone has nephrogenic diabetes insipidus, unfortunately, they will not respond to desmopressin acetate, and there are other types of medications that you could use. There are many causes of nephrogenic diabetes insipidus. The commonest cause is iatrogenic from lithium. And basically what it is thought is that lithium basically causes activation of glycogen synthase kinase 3, and that glycogen synthase kinase 3 ends up affecting how the vasopressin receptors interact with adenylate cyclase and this whole process of phosphorylation of the aquaporin. So usually that's one of the mechanisms of actions of lithium. So I hope that is clear. If you're hypernatremic with low urine serum osmolality, think about central diabetes insipidus or nephrogenic. To differentiate the two, use desmopressin acetate. And then if your urine osmolality increases, then likely you had central diabetes insipidus. If you have central diabetes insipidus, remember the original image I showed you, you could have had any infiltrating tumor to, for example, the posterior pituitary, or you've had an injury to the posterior pituitary, and or a problem in the hypothalamus where the desmopressin is actually made. So the next one, if you have hypernatremia with high urine osmolality, if it is greater than 800 milliosmoles per kilogram, this suggests secretion and response to ABP is normal, meaning the kidney has nothing to do with this. And therefore, you should think about unreplaced water losses. For example, GI, as I mentioned, osmotic diuresis, respiratory or skin, for example, in burns, in increased respiratory rate, and in fever. Or you could have total body sodium gain. Again, taking you back to the total body sodium gain, we had things like hypertonic saline, sodium bicarbonate infusion, and those things. Yeah. Then lastly, if you have hypernatremia with intermediate urine osmolality, that is between 400 and 800, this may be due to partial or central nephrogenic diabetes insipidus, and or central diabetes insipidus with volume depletion. Of course, if you have volume depletion, there'll be increased reabsorption of sodium in the proximal convoluted tubule, and this will somewhat reduce the tonicity of the urine. We saw that last week when we were talking about the kidney and everything. Or it could be due to an osmotic diuresis. So that's how you approach. So in summary, this is from Harrison's. If you have hypernatremia, think about the extracellular volume. If it is increased, think about probably those administration of hypertonic sodium chloride or sodium bicarbonate if the extracellular volume is increased. If it is not increased, you need to think about the maximum volume of maximally concentrated urine. Again, underpinning the importance of testing the urine and finding the volume and the osmolality. So the minimum volume of the maximally concentrated urine. So if it is yes, then you think about insensible water loss, gastrointestinal water loss, remote renal water loss. Okay, so if you have minimum volume of maximally concentrated urine, you think probably there were losses. If no, then you do urine osmolality. If it is more than 750 milliosmoles per day, you think about diuretic or osmotic diuresis, as I mentioned to you. If renal response if the urine osmolality is not more than 700, therefore you have to think about diabetes insipidus and then look for renal response to desmopressin. If it is increased, then you think about central diabetes insipidus, as I've mentioned. If the urine osmolality is unchanged, you think about nephrogenic diabetes insipidus, and the history would have already suggested some of the possible causes of nephrogenic diabetes insipidus, including lithium, amphotericin B, and other medications. Thank you.
All right, thank you, Dr. Preach. Just to get back to some of the poll questions. The first one, Dr. Preach, your opinion on whether hypernatremia is a water problem and not a sodium homeostasis problem. 50% of the audience says it's true, 50% said it's false. Your take?
Thank you, Dr. Cornelius. I was hoping there was an option of all of the above. But anyway, as from the presentation, you could see that mostly hypernatremia is a problem of total body water. There is an inverse relationship between total body water and sodium, and therefore I would think that's the most correct answer. But if there was all of the above from the presentation, you can see also you can have a problem. You can have excess sodium load from doctors, and you have it. Thank you.
And any opinion from the rest of the panelists? Joyce, Peter Waswa, your thoughts on that?
Thank you, Dr. Erasmus. This is Kalunji Joyce. In my opinion, hypernatremia is solely a water problem and not a sodium homeostasis problem.
Peter Waswa, thoughts?
I agree with Joyce. It's actually a water problem.
Okay. Final take, Erasmus.
Cornelius, as projected, so basically a very important clinical power is this, which is consistent with the whole question, that even in the absence of ADH, as Dr. Preach has presented, if a patient can access water, there will be no hypernatremia. They'll be able to drink to their thirst. They'll be able to lower the serum sodium level to normal. So you always want to ask yourself why the patient is not drinking water, why they would be predisposed to losing water. On rare occasions, some patients have sodium overload, like Dr. Preach mentioned, and some of them are psychiatric conditions, really, like they're trying to kill themselves. But the main thing is really about water, so I agree with most of the voters.
Okay, thank you. Dr. Preach, 2 more questions, but I think the third one will be for the sequential speakers. The second question to you is, how do we assess extracellular volume in patients at the bedside?
Thank you very much, Dr. Cornelius. And that is something I glossed over, which is very important, especially when we're discussing hypernatremia. So we need to remember, let me just take you back a step behind. Total body water is intracellular volume and extracellular volume. Now, extracellular volume is intravascular volume and interstitial volume. So it's made up of 2 things. So when you're assessing the extracellular volume at the bedside, you could do one or the other. Let us start by assessing the interstitial volume. So interstitial volume can be assessed by simple things such as skin tagger. And basically you just pinch skin, probably at the forehead, on the stomach, and you see how long it will take to the creases to disappear. And then, so that is the common one, I know, but also you could look at sinking of the eyes, yeah? That one can also be a measure of interstitial volume. Intravascular volume at the bedside, there are basic things. For example, you could feel the pulse. Usually, if someone has reduced intravascular volume, they are tachycardic, they are hypovolemic, therefore their pulse is fast, their pulse is weak, And therefore, that one would mean someone is more on the hypovolemic side. If it's really terrible, they could even have cold extremities. And the JVP is definitely collapsed. If they are hypervolemic, for example, you'd have in the intravascular assessment, you would have, amongst other things, hypertension, but also you will notice the JVP is elevated, especially if the hypervolemia is really congesting and straining the heart. In the extracellular, in the interstitial volume, when someone is overloaded, they can get periorbital edema. Interesting fact, the periorbital edema is usually the first one to come about because the tension, the resistive forces around the periorbital are very low. Therefore, in case of any extra, it can just go there. So I hope I've answered you, Dr. Cornelius. Thank you.
Thank you very much, Dr. Preach. Dr. Rasmus, over to you to proceed with the case.
So yeah, just a quick comment here. Dr. Preach, it's a very interesting part about the assessment of the intracellular volume, and that is really something that in general in the adult population we do very poorly at. There's actually a very interesting study somewhere where they looked at a number of nephrologists. I think it was the JAMA rational clinical examination the part talking about clinical examination for fluid assessment and like. I think that's where I saw it from. But basically, about 40, they got a number of nephrologists and asked to see if they could establish a patient was low on total body water just by assessing the skin turgor. And I think they only 45% right, which means they were less than even tossing a coin in terms of accuracy. Whereas these signs are quite helpful in children, they don't seem to be very good in adults. Maybe one more thing is that Duffy skin, when you pull the skin up and it collapses very slowly, but these are things that happen with very excessive water loss and they say hypernatremia. In terms of extracellular water, that's the intravascular volume, it appears, well, JVP is useful. Again, difficult to assess in some age groups, particularly people who are, and also populations like people who are fat and short neck and so on. It's quite difficult to assess in them. But now that we have ultrasonography, we can actually assess and catch such diagnostics. So and also static blood pressure seems to be quite a reproducible test for who have got intravascular volume depletion, which might be quite useful, at least of the ratio of the test that can be performed. Dr. Preach, I will proceed and kindly pay attention and really your talk has made it easy. So basically we're wondering, why did she become hypernatremic even after fasting for surgery? You know, we know that generally most of our patients don't really become hypernatremic from fasting overnight for surgery. So of course, we noted the history of polydipsia and polyuria, and when we assessed her for whatever could cause that, there's no history of diuretic use, no bulimia, no excessive sweating or diarrhea. Her blood sugar has been normal and HbA1c has been checked was also normal. So, so no diabetes. So we sent off the urinalysis, and urinalysis was grossly bland except for the serum, for a urine specific gravity of 1.005. Remember, we cannot do urine osmolarity. So we went ahead to do just specific gravity. And in the last time we had a chat on hyponatremia, we said that you can actually use the specific gravity to approximate the patient's urine osmolarity. So if you multiply the last 2 digits here of the specific gravity by 32, you kind of get an idea. So this by 32 will give us about maybe 150, 160 with one. Oh, my math is poor, but it's well less than 200, and no anything less than 200 millismoles in urine really means you're most likely dealing with no activity of ADH in the kidney, and so the patient has got diabetes insipidus. Because the question is whether it is central or nephrogenic.
So when we look at the calcium, again, like you rightly said, hypercalcemia is one of those problems that lead to diabetes insipidus, particularly nephrogenic diabetes insipidus. So the mechanism is really that, we know that ascending loop of Henle reabsorbs sodium, potassium, and chloride, and it's supposed to be an electroneutral pump absorbing 1 sodium, 1 potassium, and 2 chloride. However, we know that the filtrate generally resembles serum, such that the sodium concentration in the urinary filtrate is about 140, that of chloride is about 100, and then potassium is about 4. So if the pump starts reabsorbing sodium, potassium, and chloride, basically what's going to happen is that you are going to deplete the potassium, which would ideally stop the pump. So the kidney is designed in such a way that it will recycle the potassium that's reabsorbed, such that it's back and available for to reestablish electroneutrality. Now, at the pump itself, you'll be reabsorbing sodium, potassium, and chloride, but then the potassium is pumped back into the filtrate at this receptor called the ROM-K. That is that pump. By returning potassium into the filtrate, you end up creating a charge gradient. Basically, you've reabsorbed sodium, reabsorbed chloride, but there's no net reabsorption of potassium, which now sits in the filtrate, and as such, the overall electrolyte concentration of the filtrate is 1 charge higher. So that high charge creates a gradient for charge for paracellular reabsorption of calcium. Usually, magnesium also is reabsorbed by that, and that's how calcium is reabsorbed. Now, while potassium recycling is not really controlled, in other words, you can reabsorb and recycle potassium in the ROM-K as much as you want, calcium reabsorption is actually regulated, such that once the calcium is reabsorbed into the basolateral side of the renal tubules, there is sensing of the serum calcium levels. And if the calcium levels are high in blood, there will be shutdown of this paracellular mechanism of reabsorption of calcium. And when you shut down this, there's also and this increased calcium deficit in blood. That increased calcium tends to shut down the ROM-K receptor, which then stops the recycling of potassium. Now, when you shut down the recycling of potassium, that means the sodium potassium ATPase pump will fail, and that leads to a sodium wasting effect, similar to what loop diuretics do at the kidney level. And that will lead to dilution of the medulla, which will lead to that nephrogenic diabetes insipidus. So we thought that calcium in this case was the primary cause of the patient's problem. And so the question was, why is the patient having a hypercalcemia? Of course, now the first thing here is to look out for any signs of primary hyperparathyroidism. So we check for PTH and it's normal, which means the thyroid is actually okay. So it's not really a big problem here. So we go on to to rule out calcium coming from malignant sources. So you could do a PTHRP, which is the parathyroid hormone related peptide, which tends to be produced by paraneoplastic situations, conditions, which we didn't do here, but we also managed to check the patient's vitamin D levels alongside the thyroid level. And 24-hydroxy vitamin D is the dietary type, which was normal in this patient's case, which means the patient wasn't having raised vitamin D from ingesting food rich in vitamin D. But then the active form 125 vitamin D was raised. This was quite high. So we assumed the patient might be, so we looked for the likely causes. So usually normal dietary vitamin D with raised active vitamin D usually means something is converting it rapidly. And if it's not activity related to parathyroid hormone, then you're dealing with usually exogenous stuff, like from things like lymphomas and glomerular disease. So inquiring further on the patient's story, the patient had that history of coughing. So the chest X-ray, which came out like this with a bit of this mediastinal enlargement and hyalinopathy here, a bit of reticular stuff around the lungs. So consulting with pulmo, patient was diagnosed with sarcoidosis. So sarcoidosis was thought to be the reason as to why the patient was producing a lot of calcium, and that calcium was causing nephrogenic DI in this case. And the treatment for sarcoidosis was initiated, and that was with steroids. So the patient was kept in hospital, got very happy because sodium came down to 138 of about 1 week, but then still had a bit of polydipsia and polyuria and still drank quite a bit. But nonetheless, the patient was sent home. This is not Jen. Please ignore that picture. So yeah, so now the patient gets readmitted 2 weeks later for the planned cholecystectomy. And on arrival, unfortunately, the patient has come back and the sodium is 159. Patient's pre-op calcium has come down from 4.04 to 1.36. The patient is polyuric and polydipsic. Dr. Preach, what do you think is going on? What would you like to do next?
Thank you, Dr. Erasmus. So I can see the patient was on steroids, and so I'm curious to find out what amount of steroids they were on. In the previous slides that I shared, sometimes you could have an increased sodium load if someone has Cushing's syndrome. So I would be interested to know the amount of sodium, the amount of steroid the patient was on, then go further and check 24-hour urine, 24-hour urine steroids. Then apart from that, I would also do probably an overnight dexamethasone suppression test and see what is happening. But also I can see the patient is still polyuric. So actually, come to think of it, we have not had anything about the plasma glucose of this patient. So I'm also interested in knowing that. Thank you.
That's a good one. So basically, when the patient went home, the patient, I think, was visited by a relative who is a medic, who was concerned about the steroids. So I think the patient was put about 50 milligrams daily of bread, and so the patient became hyperglycemic. They started the patient on consult with the surgeon. The patient on oral hypoglycemics. I think they were doing Lantus. They're doing Lantus, not oral, sorry, injection. They're doing Lantus at home. And the sugars on arrival in hospital were actually in normal ranges. Patient had received their dose of Lantus the previous day. So we didn't think it was the particular issue here was, and we didn't think the issue was related to glycemia, and the patient continued to be polyuric despite the sugars being normal at home after that initiation of insulin.
Thank you, Dr. Erasmus. Therefore, at this point, then I would go ahead and try to investigate. So usually, it is very tempting at this point to say something like water deprivation test to really find out what's going on. However, if someone is hypernatremic, you first have to control that, and then you go ahead and do that. But I think this is a case of diabetes insipidus. Depending on the cranial or nephrogenic, they would have to be tested. Thank you.
So what test would you want to do?
So at this test, at this time, I would go ahead and do desmopressin acetate test, and then check urine osmolality after giving desmopressin acetate.
Right on. So basically, the patient because the patient came back with hypernatremia, had the polydipsia, polyuria, sugars were okay. We thought the patient still had DI, except that this time the question is possibly that the patient has central DI, since the obvious cause previously of diabetes insipidus nephrogenically was gone. That was the calcium. So DGVP was given, and yes, the patient's urine output dropped down to about 3 liters per day, and the serum, the urine specific gravity went up to 1.033. So patient diagnosed with central diabetes insipidus, and the question now was what is causing it. So we had to look for the central causes of, and an MRI was done, which came out with signs of neurosarcoid involving the pituitary. And the patient was basically started on DGVC, and seriously continued along with, and the patient discharged home to wait for a day when they are more optimized to actually come for surgery. So the patient kind of got lost to follow up, as is the case. We mostly get frustrated with that. And yeah, that is part of the case so far. So thank you, Dr. Preach, for helping us diagnose the patient. We managed to treat the patient, and over to Dr. Cornelius for a poll question.
Great, thank you very much. I think between the discussion of Dr. Erasmus and Dr. Preach, we therefore should be able to answer some of these poll questions now, just to see if we were paying attention. So what is true regarding hyponatremia? We shall take a minute to answer this poll question, and then we shall get feedback from the panelists. Okay, I'll end the poll now and then share the results. So 56% of the audience said serum osmolarity is always high, while 28% said 6% have normal to low serum osmolarity. I think let's get feedback from Dr. Preach regarding this. Dr. Preach, thoughts on this?
Thank you, Dr. Cornelius. This is an interesting question. I remember whenever approaching MCQs, I was told to avoid things with always, answers with always, but this is an exception. In the first slide of Dr. Erasmus, he said there's no pseudo hyponatremia. Hyponatremia is hyponatremia. And if you remember the formula for calculating serum osmolality, it is 2 sodium plus glucose plus blood urea and nitrogen. So you have increased sodium, then you multiply it by 2, and therefore its serum osmolality is always high. Thank you.
Right, thank you. Dr. Erasmus, any additions?
Yeah, I agree with Dr. Preach. So just for people to understand, about 6% with hyponatremia will have normal serum osmolarity. So that's false, just on the basis of what Dr. Preach has told us. And urine anion gap is really essential for delineating the causes of renal tubular acidosis, sorry, delineating the cause of non-gap metabolic acidosis, not the causes of hyponatremia. So yeah, the correct answer here is the serum osmolarity is high.
All right. So the next poll question regarding diabetes insipidus, which of the following is true? We shall take about a minute to respond to that. No responses yet. Okay, they have started coming in. Okay, we have about 3 seconds to the end of the poll, and I'll end the poll now and then share the results. So regarding DI, which of the following is true? 64% said hypercalcemia is a possible cause of neurogenic DI. Central DI was the second most answered part, being resulting into urine sodium loss. So I'll go to Dr. Preach to respond to this.
Maybe Dr. Cornelius, it's actually not neurogenic, I think that's the typo, it's supposed to be nephrogenic DI.
Nephrogenic, yes, it was also nephrogenic, yeah. Dr. Preach?
Thank you, Dr. Cornelius. if this was an exam, I would have lifted up my hand and asked the invigilator if the answers are correct. So anyway, yes, hypercalcemia indeed is a possible cause of nephrogenic diabetes insipidus through two mechanisms. The one Dr. Erasmus mentioned of an imbalance between the sodium potassium chloride pump, but then also the other one which I put in the chat, the one of the hypercalcemia actually reduces expression of aquaporin 2 receptors, and therefore there's no water reabsorption, and therefore you lose all the water. So yes, hypercalcemia indeed is a possible cause of neurogenic diabetes insipidus. Central DI may result in increased urinary sodium loss. Remember, in central DI, the urine osmolality is reduced, and occasionally it is borderline in case you are also losing total body water, and therefore your plasma volume is reduced, and therefore you start retaining, so less likely. Desmopressin is used in other conditions, such as in hematology. Yes, I think it's in von Willebrand's disease. I think so. Yeah, thank you.
Right, thank you. I think we shall go into the next poll question, which will be the final poll question for diagnosis. So in which of the following hypernatremic patients might brain imaging help diagnose the cause? So these are the options. Please respond. We have about 40 or 50 seconds left. Okay, in the next 3 seconds, we shall be stopping the poll. Okay, that's the end of the poll, and these are the results. So about 54% said all the above. So all these patients would require brain imaging to help diagnose the cause. Dr. Erasmus, thoughts?
Thank you, Dr. Cornelius, and all participants. So in which of the following hypernatremic patient might brain imaging help diagnose the cause? Basically, I guess we're a very brilliant group because, well, I would say all the answers there are correct. So definitely all the above is the overarching answer here. So in people who've had postpartum hemorrhage, those women risk developing pituitary apoplexy, which could lead to infarction of the pituitary due to shock, and that will lead to neurogenic or central DI. Elderly person with multiple myeloma can end up with myeloid deposition, which can happen, everywhere, including the brain. And particularly the brain, they tend to like, again, the pituitary area. And so that would be helpful as well. So in people with HIV, you can end up, and they have meningitis, particularly tuberculous meningitis in these patients. The fibrin tends to settle at the base of the brain, where, the stalk that goes down to the pituitary is, and that fibrosis and inflammation can lead to thrombosis and eventual infarction of the pituitary and its other structures as part of the problem. So yes, central DI can happen in all patients. Primarily, we are talking about people who are all at risk of getting a primary brain problem, which again can lead to diabetes insipidus as one of the causes of sodium fluctuation. Thank you.
All right, thank you, Dr. Erasmus. So I'll stop sharing that, and then we can proceed into the Dr. Osmans, we're supposed to go into the next talk, or
No, yeah, I'm going back to the case to usher in the next speaker.
all right.
All right, so we had managed to diagnose this patient with central DI, initial had nephrogenic DI, again down to the fact that the patient had sarcoid, which was treated. Patient left and got lost to follow up, and then 1 year later, there is an urgent call for transfer to the ICU. Basically, this patient underwent laparoscopic cholecystectomy at a very ambitious center near you, and 2 days later, the patient is in a coma, and after status, well, he's got status seizures and it's in a coma, so they are trying to figure out where to take the patient and then to go to ICU. So hence the call to this particular hospital. Family has asked that the patient goes back to the old doctors who cared for her. On arrival, the initial electrolyte stands out again. The sodium this time is at 178. The urine output is low. Patient is behind on volume at that time. Hypovolemic on physical examination, really. So part of the workup here, we have a serum sodium of 178, urine sodium of 30, urine potassium of 15. Urine output in the previous 24 hours was about 6 liters. At least in the 2 days the patient was in the hospital, that was about it. But now in the hospital, the patient is actually oliguric on arrival. Creatinine is about twice the upper limit. Urea also is raised. Specifically, the SG here today is 1.035, which translates to a urine osmolarity of about times 32, about 900, at least 900 something. So patient is quite dehydrated. Vital signs, patient tachycardic, blood pressure is, sorry, I didn't put some of those on the slide. Blood pressure is in the 120s systolic, but has got a significant, patient has got a significant pulse pressure variation, plethysmographic variability with respiration. So would like to usher in the next fellow, Dr.
Dr. Osmans, you're muted, I think. Okay, I think before we usher in the next fellow, we shall do that will be Joyce Kalonji to talk about management of hypernatremia. We shall go into a poll to talk about, to see how we would manage hypernatremia in this patient. So I will launch the first poll.
Sorry, Dr. Cornelius, for the interruption.
Regarding this.
Yeah.
Okay, this is the first poll, just a second. So this is the first poll. We shall take about a minute still to respond to these questions. Okay, we have 10 seconds to the end of the poll. And over 50% of the audience has responded. Okay, I'll end the poll now, and then I'll share the results. So effect of rapid correction of chronic hyponatremia in adult critically ill patients. The results are osmotic demyelination, a majority 56% chose that one. And then the second poll regarding this will be about something that we've just talked about in the previous poll. So I'm launching it now. Sorry about that. I think there's something that happened. Let me try and launch it again. Okay, the poll is here. So we shall take about a minute to respond to this. So regarding osmotic demyelination syndrome, following rapid correction of chronic dysnatremia, the higher risk is with which of these two conditions? Last week we talked about hyponatremia. This week it's about hypernatremia. Okay, we should have about 10 seconds to the end of this poll. Okay, I'll end the poll now and then share the results. So these are the results of the poll. 63% chose hyponatremia, while 38% chose hyponatremia. So I will stop sharing the poll now and then hand over back to you, Dr. Joyce Kalonji, to take us through the management of hyponatremia.
Okay, thank you very much, Dr. Cornelius. Let me share my slides. Okay, good evening, everyone. I'm going to deal with management of hyponatremia. I think all of you already know my name. So hyponatremia, like I think we've emphasized in that talk before, is a hyperosmolar problem that generally has to do with a decrease in total body water in relation to electrolyte content. And that's usually sodium that you're talking about. So like I've quoted there, it's largely a water problem and not a sodium homeostasis problem, like my colleagues have emphasized. Again, like we've talked about, it does not matter what the cause of the hyponatremia is. Usually, if a person, okay, that putting it in context, unless it's due to addition of salt, but usually the body should be able to compensate, like Dr. Preachers talked about. The ADH and the thirst mechanisms are very good at compensating when people have hyponatremia. So usually in the community, hyponatremia will happen in the elderly people who cannot, whose thirst mechanisms are altered, or in mentally handicapped people, or largely in infants. So with the hospital acquired type, usually occurs in impaired thirst response. Again, maybe someone cannot, due to central causes, cannot sense that they are thirsty and so will not take in enough, or it's due to limited access. And usually in the ICU, you have these patients usually intubated with nasogastric tubes in situ. So you're the one regulating how much water you're going to give them. So classification, my colleague has talked about classification of hyponatremia, and basically he based that on the level of serum sodium. I will base this classification on assessment of volume status as well. So there's the first type, which you can basically define as hypovolemic hyponatremia. And in this case of hyponatremia, you have lost both water and salt, but you're basically losing more water than the salt content. And basically, these people present with a reduction in the extravascular, in the intravascular fluid compartment. They are dehydrated, and they're dehydrated and hypotensive as well. Sorry. So, like the patient whom we've been talking about, the case in point, they had hyponatremia, but they also had a reduction in the extravascular fluid component. Sorry, initially I said intravascular fluid component. Then there's uvolemic hyponatremia. So basically here, you're losing just free water. You're losing just free water. Yeah, and then the next type is where you have hyponatremia with concomitant sodium gain. And usually these people are going to be hypervolemic. We've also talked about this briefly. These are people who either are receiving fluids that have a high sodium content, or it's dialysis or suicide, like previously mentioned, or they have primary aldosteronism. So the next sort of classification can be whether this is acute, and usually in acute hyponatremia, your symptoms are less than 48 hours. And this usually entails us doing rapid correction vis-a-vis the chronic type of hyponatremia, where the symptoms are more than 48 hours and there's cerebral adaptation has occurred. So the hypothesis here is that in an acute hyponatremia, you can rapidly correct, while in chronic hyponatremia, rapid correction will risk cerebral edema and coning and worse outcomes. So let's talk about the uvolemic hyponatremia. It's really the commonest type of hyponatremia. And it's, like I've said, it's you lose just pure water without electrolytes. So you maintain a normal ECF, and usually your total body sodium and potassium are normal. And this usually occurs in people, again, the previous speaker talked about it, due to impaired intake. So there's going to be increased either insensible losses or renal losses, but we are not keeping up with those losses, because like we've said, if you're able to keep up, if a patient has nephrogenic DI and they're able to keep up with their losses, they are drinking, they are less likely to develop hyponatremia. So the causes, I'll go briefly in this because the previous speaker mentioned all of them. A lack of access to water and altered mentation. These are key, and usually in the hospital they'll happen because our patients are immobilized and intubated, and we're the one controlling how much they are taking in. So abnormal thirst or adipsia usually will happen in people who as already talked about, centrally, the pathophysiology is altered and they cannot detect that they're thirsty enough. There's an age distribution to this, usually the elderly and also the infants or neonates. And then, of course, the tumors, trauma, all those things can cause central DI. And then there's nephrogenic DI as well. There are some extra renal causes, like my colleague talked about, the secretory diarrhea, where you're largely losing a hypotonic fluid in GI. So the causes of the hypovolemic hyponatremia, again, I'm emphasizing this because the management is going to differ. So we need to keep that at the back of our minds. Largely here, you're going to lose both water and solutes. You lose both. You will lose both water and salts. But there's so in this case, it's significant enough to cause hemodynamic instability. So the causes again can be renal or GI, they can be diuretics, they can be osmotic diuresis, like we've talked about. Maybe sometimes you're on drugs like mannitol, or you're having osmotic diarrhea, acute tubular necrosis, where the kidney loses its concentrating ability, diarrhea, vomiting, and sweating. So of course, one type can eventually lead into the other, just depending on of course, here you have both water and salt deficits, but what starts off as one type of hyponatremia can lead to another. Sorry, yeah, hyponatremia. So the signs. So that's here the patient has signs of hypovolemia, and this can include tachycardia and orthostatic hypotension, like the previous speakers have talked about. So essentially, when you're managing this, you need to correct the volume status and then deal with the hyperosmolarity as well. So there's the hypovolemic hyponatremia that basically occurs in patients who, in most cases, it's iatrogenic, who are gaining salt as compared to the water gain. So usually these patients can be receiving either 3% dextrose or other sodium-containing salts like sodium bicarbonate, hypertonic feeds, ingestion of seawater, dialysis, and primary aldosteronism. All these have been elaborated further. So usually these patients will have signs of fluid overload, like edema. So the management, again, the management, of course, starts from your ability to identify the etiology of the hyponatremia. So you need to take a good history examination to be able to identify the etiology. And then you need to do volume status and understand and be able to delineate whether the patient is uvolemic, hypovolemic, or they are or hypovolemic. And of course, the management is also going to depend on whether the patient has symptoms and the duration of those symptoms, whether it's acute, in which instance you need to rapidly correct the sodium, or it's chronic. So here, the mainstay, again, because most the biggest cause of hyponatremia is basically uvolemic hyponatremia, and that's why I said here that the mainstay of treatment is 5% dextrose. So the questions that you need to have at the back of your mind, just going back on this, is what is the etiology? Is this an acute or chronic hyponatremia? What is the volume status of the patient? What type of fluid do you need to correct? What type and rate of fluid do you need to is needed for replacement? During your replacement, do you have any ongoing losses? Because apart from the water deficit, you may need to correct for the ongoing losses so that you're able to hit your targets. And then do you need to replace any other electrolytes? Because sometimes due to derangements that may be caused by drugs, you may have a hyponatremia with a concomitant, maybe say a hypokalemia, rather a hypokalemia. Or in the other instance, there was a hyponatremia with calcium as well, a hypercalcemia. So the management, like we've talked about, I think, of course, from your history and examination, you're able to get the etiology, and you're also able to tell whether, hopefully, you're also able to tell whether the hyponatremia is acute or it's chronic. So then we go into some mathematics on calculating what the water deficit is. So you calculate the water deficit by using this formula. It's someone's formula whose name I will not mention. So you calculate the water deficit by getting the total body water minus the serum sodium that you have in the patient that was presented. I think it was about 178 over what is presumed to be 140, which is a normal serum sodium, times 1. So that, of course, the total body water is based off the age of the patient, and what we presume is, okay, the lean body weight. So you get the lean body weight times a certain fixed percentage. Usually it's about 0.6. We are considering a middle-aged individual. This can differ on when you're on the extremes of age. Of course, there are other considerations of course, lean body weight depends on your muscle mass. So there are muscle mass considerations. This is an estimate, so it may not be so accurate. And of course, it has some limitations. Some of the limitations being that it does not measure bound sodium, because in the body, you have the free sodium, but then you also have the bound sodium. The other limitation, of course, it's an estimate, like I've said. So depending on the fat content of the individual, the total body water will differ. Yeah, and then it does not cater for the ongoing losses. So say if you have a patient for whom you're correcting hypernatremia, you've used your current serum sodium to calculate the total body water. If that patient, however, is still undergoing losses, like free water losses, then this particular formula at that point will miss that. Like we've said, for instance, and the losses can be both insensible and gross. Like for instance, urine. Like in the patient presented, you had a serum of 178, and then over that 24-hour period, the patient had passed over 6 liters of urine. So even that has to be added, because this particular formula does not cater for your gross losses or your losses through stool, respiratory losses, or even through sweat. The other formula that you need to know is the change in serum sodium. We have a number of types of fluids that we can use to correct hypernatremia. There is 0.9% sodium, which is normal saline. There's Ringer's lactate. There's half strength. There's half strength, which usually contains about half strength, which usually is 0.4%. And it's half of that of normal saline. There is the dextrose. Dextrose can be dextrose 5%, can be dextrose 2.5%. So for you to understand, for you to know the change in sodium, because we are going to talk about the targets and the rate at which you need to correct the sodium. So for you to know the rate at which the type of fluid you're giving will correct the sodium, the rate per hour, you use this particular equation, which is listed there. Change in serum sodium, you get it, serum sodium minus the infused sodium over total body water plus 1. So, like again, I didn't put here the formula for ongoing losses, but it is there. Sorry, I didn't quote it. So after you've gotten, again, maybe we'll illustrate with a patient listed in the how these formulas work. So the recommendations for acute hypernatremia. One, when you get the patient, you will do all the things as listed above. What is the etiology? For you to be able to understand, you need to have flagged the patient. Then you understand you have acute or chronic, for which in acute, you're going to rapidly correct. Well, for chronic, you will take a bit of time to correct. I'm going to talk about the goals downstairs. Then you will use the form, you will use your hemodynamics or clinical acronym to calculate, to estimate the volume status of the patient, whether the patient is uvolemic, hypo, or hypervolemic. Then you will use the formula I've listed to calculate the water deficit, and that's formula 1. And after calculating the water deficit, you will then use the formula, the second formula, to calculate, to know the type of fluid that you need to use and the rate of fluid replacement. And then you will also calculate the ongoing losses based off your continuous assessment of the patient. You will look at your labs and see if there are any other electrolytes that you need to correct. So In the case that you have acute, and this is uvolemic hyponatremia. So loosely speaking, without going into the mathematics that I've mentioned above, the best fluid to use is dextrose 5%. So based off again the formula that we have, if you have a patient that's about 50 kilograms and they have a serum sodium of about 140, it means that it's a ratio of about 1 to 3. So for every about 1 liter of 1 liter of hypotonic fluid like dextrose 5% will correct so if you give about 3 mils per kg of dextrose 5% per hour, rather if you give about 3 mils of dextrose per kg, you'll be able to correct the serum sodium by 1 milliequivalent. So the general recommendations when you're treating acute uvolemic hyponatremia is you can start your infusion at about 3 to 6 mils per kg of dextrose 5%. This is per hour. And the maximum rate that you can go at is about 666 mils. So here you're targeting to correct the sodium rapidly. Again, this should be about by about 1 to 2 millimoles. And the presumption is by 24 hours, you'll have normalized the sodium. So while doing this, you need to constantly monitor your serum sodium and of course your random blood sugar. This is a rate of about 1 to 3 hours. And of course, you should continuously perform CNS examinations, So once the serum sodium is about 145, then you will drop the rate of infusion to about 1 mil per kg per hour. Now, management of other causes. Of course, one of the commonest causes of uvolemic hyponatremia is diabetes insipidus. So in the case of central DI, you will need to give some desmopressin. Hyperglycemia is one of the causes of hyperglycemia can ensue or due to patient's physiology, or sometimes is a cause of hypernatremia. So in that case, you may need to either give a slower rate or give a smaller concentration, like of about 2.5% dextrose. So in patients who may have hyponatremia and oliguria that is persistent, they may require dialysis. Again, like in the case presented below, the patient was starting to get oliguria, maybe due to prerenal AKI. But if the oliguria is persistent and the patient has hyponatremia, then you may need to consider dialysis. For other causes of hyponatremia, and this includes the hypovolemic hyponatremia that is acute, then largely you need to correct the fluid status before you deal with the osmolarity. So that can entail giving crystalloids. So that can be either so normal saline or at least half strength ringers. Diuretics have a role in hyponatremia that is due to hypovolemia, rather hyponatremia that concomitantly occurs with an increased ECF. So this usually occurs in patients who are receiving sodium-containing fluid like 3% dextrose or sodium bicarbonate. So I've talked about this, about the performing of serial neurological examinations. And I think one thing to point out is hyponatremia can also be a consequence of patients who have hyperglycemic emergencies, like in DKA, and honk. So the recommendations for chronic hyponatremia. So usually the majority of the patients that you see with hyponatremia largely have chronic hyponatremia. And that means that they've had the symptoms for more than 48 hours. Here, basically, you want to correct the hyponatremia more slowly than you would in acute. And this basically, you're targeting about a change of about 10 millimoles in 24 hours as compared to the 1 to 2 millimoles per hour that happens in acute hyponatremia. Usually, if patients are having neurological symptoms, and this is altered mental state, that means you're going to use an IV, that's intravenous fluid, to correct the hyponatremia, and we still stick to the 5% dextrose. You go through the same sort of procedure where you have to calculate the water deficit. Then you have to also understand which type of fluid you're going to use and the rate at which you're going to infuse it to get this particular outcome. So when a patient is fully conscious, though, the replacement can be done orally and not in IV format. Yeah. That's what I had. These were the references. I'll talk about the evidence, though. Of course, most of the evidence that speaks to this target, like in chronic hyponatremia, are studies that have been done in largely infants and neonates, where rapid correction of hyponatremia will lead to cerebral edema. So in adults per se, there's no vivid evidence that rapid correction of chronic hyponatremia will lead to cerebral edema, but we just extrapolate. The two populations that, of course, people worry about are people who have hyperglycemia, that is hyperglycemic emergencies, and then the infants. Yeah, that's what I can say. I hope I've been able to make things clear through the references.
Thank you, Dr. Joyce. I think I will request you to make some responses regarding the poll questions. Here is one of the poll questions. What is the effect of rapid correction of hyponatremia in critically ill patients? We see here that 56% chose osmotic demyelination. Thoughts on that? Dr. Joyce?
Oh, so cerebral edema is the answer.
Okay, and do you mind trying to explain to those who had osmotic demyelination why they are correct?
Oh, okay. So osmotic demyelination basically occurs in a state of hyponatremia, which is when the cell undergoes shrinking. Cerebral edema occurs due to rapid correction of chronic hyponatremia. So what basically happens is when you have hyponatremia, of course, there are your brain cells, and then there is the extravascular compartment. So when the hyponatremia occurs, it means there's going to be a movement of water from your intravascular compartment to your extravascular compartment to sort of compensate. Now, how the brain deals with that is that it will not only pull osmoles, other osmoles, including protein and what, into the intravascular compartment in the first 24, and this happens between the in the first 24 hours, where there is pulling of water from the interstitium, but also other osmoles to try and compensate. So this mechanism takes about 48 hours, and it compensates for the hyponatremia in the acute phase. So when you rapidly correct chronic hyponatremia, which is beyond 48 hours, it is presumed that the fluid will move now from the extravesicular compartment back into the brain cells and cause edema and at worst cause cloning.
Okay, thank you for that. Dr. Rasmus, any thoughts in addition to that?
Thank you, Dr. Cornelius. Thank you, Joyce, for your presentation. We'll be carrying on at some point, but regarding the poll question itself, yeah, I guess it will be answered even better after the next speaker's presentation. But I agree, overall, there has not been a case of cerebral edema demonstrated in the adult population. This is generally something that is seen with the children. And similarly, osmotic demyelination syndrome has not really been demonstrated. Apparently, I've not seen a case of such presentation after rapid collection of hypernatremia. But hopefully the next speaker will tell us quite a bit more. So perhaps the answer there is we don't really know, or maybe it doesn't matter. We don't really know. So yeah.
Okay. And then this was the other poll question. So I think this Dr. Joyce can tell us which part of the audience was correct. Is it hyponatremia or hyponatremia that is more associated with osmotic demyelination syndrome? I think from your explanation, the audience would like to know what you're going to point at.
I am going to say hyponatremia. Yes, Dr. Rasmus, I think, says neither, but in my opinion, I'm going to say hyponatremia.
Okay, thank you for that. So the other questions that I have received, the first one is about when to stop correcting hyponatremia. A recent pilot RCT seemed to suggest a benefit of induced hyponatremia in moderate to severe ARDS patients. So Dr. Joyce, any thoughts on that?
When the first question is when to stop correcting hyponatremia.
Yeah, and the addition was that an RCT seemed to suggest hyponatremia being beneficial in moderate to severe ARDS.
Okay, so for the acute hyponatremia, ideally you correct. Ideally, within the first 24 hours, there should be a normalization of the sodium, meaning from whatever point you're getting it at, you maintain. Okay, you aim to correct it to about 140 in 24 hours. For the chronic hyponatremia, however, the normalization of the serum sodium can take up to about 48. Some literature says even up to 72 hours of correction, which is a serum sodium of about 140. So in chronic hyponatremia at about 145, you will change the rate of infusion to about 1 ml per kg per hour, like already talked about. Then the dilemma is going to my dilemma is if you have not dealt after normalization of the hyponatremia, if you have not dealt with the cause, with the ongoing, you will move from a phase of resuscitation and then you'll go to a maintenance phase. And the presumption is you're going to deal with the cause of the fluid loss. That's my presumption. But again, briefly, hopefully I've not confused anyone. The normalization should take about 24 hours in acute and up to 72 hours in chronic, for which you continue with the maintenance fluid. And in this case, if the patient is fully conscious or has an NG tube in situ, you're going to now give the maintenance fluid orally. I hope I've been able to.
Okay, and any thoughts on induced hyponatremia being beneficial in moderate to severe ARDS?
I think just by biological plausibility, I would think that it would be beneficial. I have not read the RCT, but I would think it would be beneficial simply because, just loosely saying, it would give you like a dry, like it's sort of a mechanism to dry the lung up. Yeah, so I haven't read the RCT per se. Yeah, but for me, just scientifically, by biological plausibility, I would think that if the patient was a little bit hypernatremic, then there would be a clinical benefit because sort of you have a drier lung.
Okay, Dr. Erasmus, any thoughts on those issues raised?
I agree about the rate of correction of the sodium by said by Joyce. If it's acute, you really want to normalize it quickly. There's really no risk that you're standing there and just get overweight in like 24 hours. Of course, minding how much volume you have to give versus where it has to go and where the patient's cardiovascular system is going to tolerate it. You might be needing to pump in like half a liter of fluid into a patient per hour. It may have a limit too versus the rate of transit of such fluid into the cellular space. So those are some things you have to consider. But yes, you can correct acute hypernatremia rapidly. But remember, of course, the assumption is that hypernatremia is down, acute hypernatremia is down to fluid loss. In some situations, maybe due to water intoxication, salt intoxication, as we have learned today, in which case the use of diuretics might be helpful. Remember, the case now going to be hypernatremic and hypervolemic. So giving them a lot of water in the name of correcting hypernatremia could actually put them into cardiocirculatory failure. So you have to remember the mechanism and apply the appropriate intervention. For chronic, the first question is the patient symptomatic, and you may have to address that. So maybe Cornelius, if you don't mind, since it relates to the problem I have, and Joyce is still kind of hot off the, the frying pan, I want to continue with her here on the case. So this patient of mine is actually the chronic but symptomatic patient. We don't know what her serum sodium was when she went to have the lab chole. Those things were given to us. So we assume that whoever comes with a hypernatremia that is of indeterminate duration, we assume it's chronic. But she is unconscious, she's been seizing, so we assume all that is down to the hypernatremia. So when we evaluate a bit more, we find that the patient has abandoned DBAVP spray because of the cost. So we don't know how long she has not been taking it. Also, the patient had stopped their steroids due to weight gain and becoming slay. In other words, she was getting a fair skin with nice stretch marks and the like. She didn't really like the look because she's a traditional African woman. The polyuria and polydipsia had recurred and they're quite significant over time. But then after surgery, it looks like she went to the ward after surgery, her lab chole. She was still kept NPO, as is the case with our sweet surgeon, kept her NPO for quite a while. She wasn't really getting all her fluids because of the quality of nursing care that she had. Then on this particular day, she deteriorated, ended up having seizures and got transferred to us. So Joyce, what would be your first course of action in this patient arrival?
Okay, thank you, Dr. Erasmus. So the first course of action, of course, the patient is unconscious, having seizures, so you have to deal with the ABC. And yeah, you've talked about a bit of the C. So this patient has chronic symptomatic hyponatremia. We know the cause. So we have to deal with the hemodynamics. I presume we've dealt with the airway, breathing, and the seizures. So now we are dealing with today's topic. We have to first, so this patient has hypernatremia, but they are also hemodynamically unstable based off the tachycardia, the orthostatic hypotension, and the oliguria that you've mentioned. So that means the patient benefits from receiving a crystalloid. So it would be good to first calculate the total the water deficit that we calculate. I hope everyone can sort of recall the formula in their mind. You calculate the total, the fluid deficit, and then also to calculate the type of fluid that you need to use to correct the hyponatremia. What I would do, me personally, with avoiding all the politics, I would put 2 large bore cannulas and give normal saline, which is 0.9%, about a liter. And I start with the resuscitation of the patient. And then because I know that it would take very huge volumes.
How rapid do you want the normal saline to go in? How rapidly?
Okay, so I would say about a liter in the first 1 hour. Just of head. I have 2 dilemmas here, Dr. Erasmus, about the fluid that I'm choosing to use. Of course, we know that we have a depleted volume status, but with the correction of hyponatremia as well. So I'd want to use the formula to see how I could correct the hyponatremia using a hypotonic fluid, because I'd want to give both of them at the same time. But now, due to the depleted volume status and impending signs of shock, I would want to start with a normal saline, at least a liter in the first 1 hour, and continue the assessment.
Okay, thank you. Let's first hold there. So yes, so you're right. The first thing here is the patient has life-threatening issue. Hypernatremia is a secondary issue. We don't care. For the first few minutes, you want to first make sure the patient is alive enough to risk developing any complications of your correction of hypernatremia. So the first thing is secure the patient's airway and ensure the patient is breathing fine, oxygenating. That means they are going to have a pulse. And as long as they have a pulse, you have a chance to eventually fix problems. Saturation, you're going to correct the hypovolemic state. This patient is basically hypoperfusing an organ, which basically means the patient is going to shock. We don't know whether the seizures and augmentation are down to just hyponatremia, or there's actually an element of hypoperfusion of the brain as part of the complication. So you want to correct perfusion rapidly, and the most readily available fluid, which is probably fair to use here, is normal saline. So use normal saline. Of course, expand the volume rapidly. And of course, the question is whether you could have used ringer flaccid as well. I honestly don't know the answer to it, and I don't think it really matters much. The issue is that if you can get blood flow through the body and into that brain quite fast enough, and as kidney, then you have a chance to worry about some of the complications. So yeah, the patient gets intubated, the patient gets fluid. So how rapid you give the fluid for resuscitation? This is not a unique situation. You're going to give fluids as rapidly as you usually give for other forms of hypovolemic shock, monitoring for fluid responsiveness and an endpoint of perfusion. So in other words, how's the capillary fill time, how's the urine output, how's the mentation, where if you can assess it, how are the hemodynamic measurements, that is the blood pressure, the orthostats if you can, the heart rate, how are they, and how is the peripheral perfusion overall. So you do that initially, and then the next step is, as you mentioned, you want to go on to determine to the fluid deficit. Now this is a fine tuning, and maybe I need your help here, Joyce. You do select, you have to determine the target of sodium. This is a chronic type. You determine the serum target. So let's assume that after using normal saline on this patient, the sodium drops to, we're given about 2.5 liters of fluid, and at that point we start establishing good urine output in the patient, and we have stable hemodynamics finally. And the patient is perfusing well. So we are not slowing down to focus on sodium. So we repeat a point of care test for sodium, and find that it has dropped from 178 down to 170 in that time of intervention. So how are you going to proceed from there? 170 is the serum sodium. So you determine the sodium target. What target do you want to set for this patient, Dr. Joyce?
Okay, so if the serum sodium is now 170, I would wish to reduce the serum sodium by about 10 millimoles in 24 hours. That approximately is going to give me about 0.5, a reduction of 0.5 millimoles per hour. So I would go and use the formula first to calculate I would still calculate the deficit. I think people can be able to do that on their phones. Let me use, for instance, MedCalc. You want me to go specific? So I would calculate the deficit and then lower it at a rate of 0.5% using probably dextrose 5%. 0.5 millimoles per hour using probably dextrose 5%.
We shall talk about the fluid. So the patient has, so in this case, let's say the patient has got a serum fluid of 170. Our target sodium, you said you want to reduce by 10 millimoles in 24 hours. That means you want to go from 170 to 160 in 24 hours, right?
Yes.
So that will be our, so just doing a simple calculation. I am just going to activate my calculator where I am. Sorry, Dr. Cornelius might be taking a little bit of time, but I need to get this right for everybody practically, because patients get screwed up from poor mathematics. Okay, so we have 170 minus 160 divided by, what do we put as the denominator, Joyce?
So the denominator is total body. Yes, you can hear me. Total body water.
That is the multiplier.
Yes.
That is what you multiply by.
Wait.
So the equation for fluid deficit is the serum sodium minus the target sodium divided by the target sodium multiplied by total body water. The equation you gave us earlier on looks at the total fluid deficit, which is 178.
So it's total body water. Sorry. Oh, sorry, Dr. Rasmus, you can go ahead. Sorry.
The equation you gave us was more of the serum sodium, which is 178, minus the target sodium, normal sodium, which is 140, which will be divided by 140, then multiplied by total body water, which in this case is an elderly woman, would be her weight, which is 70 kgs, multiplied by what multiplier?
So we are calculating the volume, the water deficit, Dr. Rasmus. Yes.
Yes, please. Yes.
Yes. So it is the total body water which you get if she's elderly. You presume, you get her lean body weight, which is 70 times about 0.5 minus the serum sodium, which is 178 over 140. That's in brackets, then times 1. The multiplier is times 1. Yes, Dr. Rasmus?
So in this patient, you said the total body water for her is going to be 70 kgs?
Yes, so 70 kgs times 0.5.
0.5, which is 35.
Yes.
Okay, and you say subtract?
So you subtract the serum sodium, the current serum sodium, which is 170.
Okay.
Over 140, which is, okay, 170 over 140, which is presumed to be the normal serum sodium.
Okay.
Yes.
Gives you
times 1. Yes.
Which is 1.2 liters.
Yes.
So that means the patient's total water deficit is is a 35 minus 1.2, which comes down to just 34.8. Looks like a very big one though. Okay, let's try using this other equation.
The med calc. Okay.
Okay, let me use this equation. So serum sodium is 178.
Okay.
Subtract 140 from that. That gives us
178 minus 140.
Which is 38. Divide that by 140.
Okay.
That gives us 0.27.
Yes.
Then multiply that by 35, which is the total body water for this old lady.
9.5.
And that 9.5 is the water deficit in this lady. So that means if we give a total body water, just free water of 9.8 liters over whichever period, you end up with a sodium coming down to 140. Of course, assuming no extra losses. So you are accounting for extra losses. But then when you are going to correct chronic hypernatremia, in this case, the sodium was 170 after the fluid resuscitation. In this case, you choose a target. The target is going to be 10 millimoles less than the serum sodium, which is 160. Okay? This gives us 10. Divide that by the target, which is 160. And that gives us 0.625. Multiply that by total body water, which is 35. And this gives us 2.2 liters. So we're supposed to give about 2.2 liters in 24 hours as fluid deficit for just correcting sodium from 170 to 160. So after you calculate that, you, like you said correctly, you look at the ongoing water losses. Now, how do you estimate the ongoing water losses, Dr. Kalunji? Practically.
Practically. So the ongoing water losses, you have the insensible losses, then you have the gross water, the micro water losses, like your urinary output, which you can get from your bag. For the sweat, the losses through the respiratory system and the GI, there is an estimation, just an estimation that you use to get the ongoing water losses.
Okay, so there is a formula for estimating the ongoing free water losses in the kidney, and it's a long formula, basically looking at the urine volume multiplied by, sorry, not equal sign, but multiplied by, in open the brackets, 1 minus the urine sodium plus urine potassium over serum sodium. It's a long equation, it's stressful. So a good nephrologist was kind to teach me an approach where to estimate the free water in the urine. Remember, when urine is produced, urine that is lost just due to the other osmolytes like urea and the glucose and the like. But then there is urine that is lost due to electrolyte. So you want to capture the electrolyte-free water. That is what you're going to replace in the patient. So electrolyte-free water can be estimated just by looking at the total volume of urine. So to do so, this patient is producing about 6 liters of urine. So what you'd have to do is to say the first liter of urine, you ignore it. The free water losses, they are going to be insignificant to the problem we have. For the next 2 to 3 liters, you are going to add half a liter. So in other words, for the next 3 liters, that is from liter number 2 of urine to liter number 4 of urine, you are going to add half. So that would give us 3 liters times half gives you 1.5 liters. So approximately 1.5 liters of free water. And then for every liter beyond 4 liters, you're going to add 1 liter. So that would mean 2 liters plus 2.5 plus 1.5 would give us about 3.5 liters of free water. And then you add that to what the deficit you calculated. And that would bring us to, the deficit was 2.2 liters. So that would give us about 2.2 plus 3.5, about 5.7 liters of water. So that is the amount of free water that is supposed to be running in this patient per day to be able to, one, arrive at the sodium target of 160 while avoiding any further drops in sodium. So the commonest mistake, like you mentioned, is that people calculate the fluid deficit and administer that, forgetting that there are ongoing losses. So when you do that correction, you definitely end up with at least a net reduction of sodium. So Dr. Joyce, what is your fluid of choice? You said it's dextrose 5%.
Yes.
So if we are going to give 5.7 liters of fluid in 24 hours as dextrose 5%, let's assume, round it off to about 6 liters. That's 6,000 ml of dextrose divided by 24. That to give us about 250 ml of dextrose going into the vein per hour. Okay?
Yes.
Now, dextrose 5% contains 5 grams per 100 ml. Per 100 ml of glucose of the solution. That would mean 250 would give us 2.5 times 5 grams gives you 7.5 grams. Is it 12.5 grams? So 12.5 grams per hour multiplied by 1,000 would give us 12,500 milligrams per hour going into the body. If you distribute that by 5 liters, assuming 5 liters, you would end up with about 2,500 milligrams per liter in the blood of glucose in 1 hour. So your kidneys are only able to reabsorb up to 180 milligrams per deciliter.
Okay.
So which means any extra glucose is going to be still in the urine and you end up with osmotic diuresis. So this is why intravenous dextrose will not be the most appropriate fluid in total to give this patient. Remember also that if you're running it at 250 ml per hour to correct hyponatremia, it means that the nurse is going to be changing that bottle every 2 hours. And no nurse is going to be very excited to be doing that. Of course, if you're lucky, you might be working in a center where you have 1 liter bags of dextrose 5%. So in that case, what will happen is they'll be changing every 4 hours, which is still a lot of work for a nurse who has other aspects of the patient care to do. So the entero route, whenever it's functional, tends to be more useful because you can give quite a large amount of entero water. It is safer, there's no osmotic diuresis, and the gut will absorb what it needs to take and discard the rest. So it appears the best fluid of choice is ideal as long as the entero route is working, use water for correction. Of course, if you find that you're probably spending a lot also on the water, maybe the patient's not really having poor GI motility, then you might have to divide the fluid between IV and the entero. But I agree with you, a hypotonic fluid is going to be very useful for this patient. So I don't know. So Joyce, is that clear at least, or you have some questions?
It's clear. Thank you, Dr. Rasmus.
All right. So now our patient here on the first day of correction, on the first day of correction, our patient's sodium went from 178 to 159. So
Rasmus,
that is, yes, sir.
There's some questions there's some people who wish to ask questions regarding the discussion. I think regarding the correction especially. Could you allow me to allow them to ask? One of the questions here is, I think Semei Mutesa said, I think let me just allow them to unmute so that they can ask directly. So Semei, you have been allowed to talk. Please go ahead.
Thank you, Dr. Eras, the entire team. I was wondering on that part of when you're calculating the water deficit for chronic versus acute, I got to understand the acute, but then the chronic bit where you came to about 2 liters for that patient. If you could just kindly recap that, thank you.
So when you are going to correct sodium, you want to be safe. I know that we've said already that cerebral edema and the osmotic demyelination are not really things that were demonstrated, but we are still governed by the rules of the assumption previously held. And as such, we still want to take into consideration that possibility that the patient could overcorrect and end up with problems. So you set a fixed target of the fixed target sodium. So in our patient, after fluid resuscitation, volume expansion from for the hypovolemia, our serum sodium was 170. So we assume that we want to lower it by 10 from that point. Of course, the correct thing to have said is we want to lower it from 178 to 168. But let's just for purpose of calculation, from 160 to from 170 to 160. So in that case, you apply the equation on the screen, the second text box at the bottom, serum sodium minus target sodium. Serum sodium is 170, target sodium is 160. Divide that by the target sodium. And then multiply total body water. Total body water is estimated by multiplying the weight of the patient by a conversion factor. In adult men, adult healthy men, we assume that their body is mostly muscle, and as such, it's about 60% water. So total body water in adult men will be total body weight multiplied by 0.6. In adult healthy women, we assume it's 50%. So it is going to be 50% times the weight. In the elderly, which actually I think is, now that you mentioned, it's actually an error in our calculation. The elderly, it drops about 0.45. And similar in the obese, it's about 0.5, 0.45, depending on the resource you use. So you find the estimated total water deficit that you want to correct in that 24-hour period to lower the sodium from 170 to 160. Now, after calculating, we found that our deficit would be about 2.2 liters for reduction of sodium from 170 to 160. However, the patient also is having ongoing urinary losses of free water. So you want to put that ongoing free water loss into the calculation for the day. So you estimate from the urinary volume, and the proper way of calculating is given by the formula on your screen on the third text box at the bottom. Urine volume multiplied by what comes out of that bracket. Now, this calculation is a little bit hard to follow, but so here you need to do urine electrolytes, urine sodium and urine potassium, and then get the serum sodium. Then you calculate the total electrolyte free water loss in this patient. What you find there, you add to the water deficit that you calculated earlier. That gives the total amount of free water you must give this patient per day to 1 prevent any extra loss, extra reduction in sodium while you are trying to address the deficit of yesterday to today, which is 170 to 160. Then the next day, you will recalculate. You recalculate the water deficit and also the electrolyte water losses. So it's an ongoing procedure. So most people, of course, cut their losses by that formula I was telling you about, where you can make an estimate of the electrolyte-free water losses by just looking at the urine volume. And like I said, if the urine volume, in this case, if the patient is producing below 1 liter of urine per day, you don't have to add it. You have to consider it because the water losses there are insignificant to cause hypernatremia. But if a patient is producing up to 3 liters of urine, sorry, you ignore the first liter. So if a patient is producing anything more than that, so from 2 liters to 4 liters, for each liter, it contributes half. It contributes half a liter of water losses. So that will mean 3 liters times half, which gives you 1.5 liters of water lost in that situation. Then for any extra urinary losses beyond 4 liters, you add 1 liter of urine, of urinary water per liter of urine. So in this case, the patient produces 6 liters. That means beyond 4 liters, you have 2 extra liters. So 2 liters plus 1.5 gives you 3.5 liters of urine, of water, free water lost in urine. So now you add that to the water deficit the patient had. And that will give you 2.2 plus 3.5, which comes down to 5.7. Now that 5.7 is what you're going to distribute across the hours of the day to give in a 24-hour window to achieve the target that we wanted to achieve. Seme, is that clear now?
Yes, Dr. Raz, thank you.
Dr. Cornelius, any other questions?
None.
Okay, so we said that the best fluid really for sodium correction is going to be enteral. So you're talking about water, you're talking about feeds, something hypotonic, but make sure water is going through the enteral route. Of course, if it is too much and it's overwhelming the gut, then you may have to divide it and have some go through as dextrose. But receive the temptation of giving dextrose, if say beyond 120 mils per hour, you're going to be giving a patient a lot more glucose beyond what the kidney can reabsorb. And as such, you'll end up inducing an osmotic diuresis where the patient will end up, countering what you're trying to achieve. So yeah, so I think now, Dr. Cornelius, I would like to, so Dr. Joyce, our patient, like I said, overcorrected from day one. So should we be worried? I think we've answered the question partly by talking about the issues, the concerns of osmotic demyelination and cerebral edema. This is an adult patient, she's elderly. We are probably not so worried, but maybe let's hear from the next speaker. So Dr. Cornelius, over to you to introduce the next speaker, and then we'll conclude the evening.
All right, thank you very much. So the final poll questions are really going to be about last week's topic, which was hyponatremia. And so at what rate would you correct chronic hyponatremia? Dr. Rasmus, was this supposed to be hyponatremia or hyponatremia?
It's supposed to be hypernatremia, so there's so many typos in your work today.
Yeah, I just noticed now. Okay, if it was hyponatremia, it's fine. Let's go with hyponatremia as per last week, since the next talk is about dysnatremias in the ICUs. Okay, so about 30 seconds to the end of this. Okay, and now about 10 seconds to the end of this. Then I'll end it in about 5. In the meantime, Dr. Washopita, please share your slides. Okay, I'll end the poll here. So a majority of the audience has chosen 0.5 millimoles per hour. We shall get the answers at the end. I will launch the next poll question, and that will be the last poll question. So I think this is supposed to be hypernatremia. Please use hypernatremia here. Hypovolemic hyponatremia. Which of the following is the best initial approach to correction of symptomatic hypovolemic hypernatremia? So don't read it as hypo, read it as hypernatremia and answer the question. Okay, symptomatic hypovolemic hypernatremia. We have about 20 seconds left to close the poll. Okay, in 10 seconds, we shall be closing this poll. Okay, so I'll close this poll now. And these are the results. A majority of the audience chose to correct symptomatic hypovolemic hypernatremia with IV normal saline bolus. Okay, I will hand over to Dr. Peter Waswa, who is I think is now an additional fellow, additional resident, about to be a fellow in critical care, and is going to talk about complications of correction of dysnatremias. So Dr. Peter Waswa, please take it away.
Okay, thank you, Dr. Cornelius. Peter Waswa is my name once again, so I'm going to be taking us through complications of correction of dysnatremia. So, for purposes of today's discussion, we are going to focus on osmotic demyelination syndrome and then cerebral edema. So, osmotic demyelination syndrome, that name actually was coined in 1959. Victor and Adams were noticed a certain pattern in patients that were malnourished and alcoholic. So those patients used to have quadriparesis, pseudobulbar paralysis. So at first they thought it was actually because of those two things. When they did postmortems, they discovered that actually most of these patients had loss of myelin, and then it was mostly within the bones. So they came up with the name of central protein myelinolysis, which was actually later on changed in 1962 to osmotic demyelination syndrome. So in 1976, Tomlinson made a suggestion. He was able to come up with a suggestion to correlate rapid correction of hyponatremia with osmotic demyelination syndrome. And then in 1981, that's when actually it was really confirmed that rapid correction of chronic hyponatremia was associated with osmotic demyelination. So what happens is, it is known why the name was changed from central protein to osmotic demyelination was when they did postmortem. It was not actually patients had other parts in the brain spinal cord that were actually having manifestations of loss of myelin. And actually, the population of patients that were sampled, half of them had only central protein myelinolysis involvement, whereas 2/5 had extrapontine manifestations, and 3/5 of them had both central pontine and extrapontine manifestations. So what exactly happens? So from the previous presentations, we've been told that when a patient gets a hyponatremia, the brain cells take about 2 days, about 48 hours to adapt to the new state. So what exactly happens? When you're having hyponatremia, the cells within the brain are more osmolar than the blood. So what is supposed to shift from the blood into the cells, and then they swell. So what the cells do within those 48 hours, they undergo some changes. So they create new channels, and then they kind of release idiogenic osmoles from the intracellular compartment into the extracellular compartment, so that they achieve a certain form of equilibrium. So some of the idiogenic osmoles that are released from the cells to the surrounding are glutamate, glucose, and then other idiogenic osmoles. So in the sense, they tend to re-establish their cell volume. Now, when a patient comes in with chronic hyponatremia, and then you rapidly correct the sodium, you don't give the cells time to adapt to the new normal, the cells swell. To be specific, the cells of interest are the astrocytes. So when they swell, they end up breaking down, and then because the astrocytes have been damaged, they're going to lead to release of cytokines within the system. So the cytokines are going to activate microglia cells, which actually move immune cells within the brain, which are going to try to come and try to arrest the inflammation. In the process, they cause more inflammation, and then we are going to have destruction of oligodendrocytes. So with destruction of oligodendrocytes, what happens is we are going to end up with loss of myelin sheath, and then end up with the demyelination. Maybe point to note is this demyelination is not purely inflammatory, because the images that they do, they don't find inflammatory processes, but it's with the inflammatory mediators. So who are the people at risk for getting osmotic demyelination? Those that have rapid correction of hyponatremia, for those that have chronic hyponatremia, the alcoholics, post-liver transplant, and malnutrition, the malnourished. And then these are the other groups of patients that are not uncommon, but are at risk of having osmotic demyelination. So patients, the features happen between 2 to 6 days after the rapid correction. And then these symptoms the patients are going to present with are some of those that are displayed. But what happens is, remember, the signs the patients are going to present with are going to depend on the specific structure within the brain that has been damaged. Because when it comes to the pons, remember the pons, we have a number of cranial nerve nuclei. With demyelination, we're going to have issues with it. And then the tracts, those are the spinal tracts, and those which are also pass through the same tract, are going to be involved. And then other extrapontine manifestations also going to be involved. So how do you diagnose a patient with osmotic demyelination? So it's you must have a high index of suspicion. And then for the purposes of this discussion, the patient should have presented with chronic hyponatremia and then rapid correction. So the imaging modality of choice is MRI. So you don't need biopsies to confirm osmotic demyelination syndrome. So the four goals of management are you would actually want to prevent your patient from getting osmotic demyelination. In case it happens, you want to relower the serum sodium. You may want to offer supportive care. And then there are some experimental therapies. However, of those experimental therapies, none has been yet confirmed in humans, but there are some animal studies. So how do you prevent? By watching your rate of sodium correction not to exceed 8 milliequivalents per liter in 24 hours. And then before you begin your correction of sodium, you want to assess if there are other risk factors for the patient to be exposed to osmotic demyelination. So what are the goals for your sodium? So some literature talks about 0.5 milliequivalents per liter per hour. And then others talk about 1, that's the target. Sorry, this T5 was for hypernatremia. Then supportive care. So patients, so one of the complications is patients end up with a vegetative state when they can't even actually assist themselves to breathe. So you want to do ventilation for them. You want to offer physiotherapy and neurorehabilitation and anti-Parkinson medications for those with Parkinsonian syndromes. So these are investigational medications which have been used in animal studies, and then they found some relief. So I came across a case study where they did plasmapheresis, and actually they had a reversal of symptoms. So maybe it's something to look into. So that's it for osmotic demyelination syndrome. The other complications I'm supposed to talk about is cerebral edema. So from the previous presentations, we've been able to know that when patients present with chronic hypernatremia, and then we do a rapid correction, they end up with cerebral edema. So how do cells respond to hypernatremia? So with the hypernatremia, we expect that the cells are going to lose water to the extracellular compartment because it is more osmolar than the cells. That's in the initial phases. However, within the brain cells, in the initial phase, we are going to have loss of the intracellular volume. But within 2 days, we are going to have influx of idiogenic osmoles, and then we shall have restoration of the cell volume. So what happens is, in case a patient comes into chronic hypernatremia, and then you rapidly lower the serum sodium, you're not giving the cells enough time to adapt to the new normal, and then patients end up with cerebral edema. So the patients at risk are patients that are young, which quotes patients less than 40 years. So the logic was patients that are advanced in age really have enough volume within the brain. So cerebral edema may not be much of an issue from the correction. And then patients that may have active neurological disease with pre-existing cerebral edema. Maybe to note, the cerebral edema that we note in patients with hypernatremia that have had a rapid correction is the cytotoxic form, though sometimes it's actually a mixed form for both cytotoxic and lysogenic because of cell damage. So the clinical features are going to be the same features of patients that are having cerebral edema. They may have the vision, they may have a headache, they're going to have patient that was recovering, and then the patient is actually having deterioration in the Glasgow Coma Scale or level of consciousness. So diagnosis, you basically need a high index of suspicion. You may do imaging, though you can even diagnose that your patient has going to cerebral edema without imaging. Imaging of choice, in case you're to do one, is a plain CT scan. So what would one do to prevent your patient from developing cerebral edema? You'd want to be careful on the rate of lowering your sodium, and then you regularly assess how much food you're giving your patient based on the sodium levels, because you set a target before you begin the correction. So how would you manage cerebral edema? So diuretics like mannitol have a role. You may want to replace the sodium, though I've not come across literature that gives specific rates of and targets of how to replace. That's if you've overcorrected, and then you want to do steroids for the cytotoxic form. That's the end of my presentation. Thanks for listening. Those are my references.
Okay, thank you, Dr. Peter Waswa. I think let's see if you could maybe respond to some of the poll questions. We shall start with this one. Your thoughts on this poll question?
Freedom is for correction of symptomatic hypovolemic hyponatremia,
hypernatremia, sorry.
Yeah, hypernatremia. But actually go in for dextrose 5%.
For hypovolemic hyponatremia.
Hypovolemic, no, normal saline.
Yeah, okay. And I think Dr. Joyce also had elaborated on that earlier. And then the other question, the final one, was about, let me just get it. The rate at which you would correct hyponatremia. The options were 1 millimole per hour and then 0.5 millimoles per hour.
So different, I've come across different quotations. Some people quote 0.5, whereas others quote 1 millimole per hour. So both are quoted, which would mean that it depends on the protocols for the setting.
Okay. And what if this was chronic hypernatremia? How fast then should we correct it? As per millimoles per hour, 1 millimole, 0.5. So
for chronic hypernatremia, both have actually been quoted, and then actually some literature quotes that even those that have been corrected with 1 millimole per hour, they've actually not had issues.
All right. So Dr. Rasmus, over to you to wind this up.
Yeah, so Peter, thank you very much for your presentation. And I guess first is that, the patient is hypovolemic hyponatremia. The concern is to reperfuse the patient. So go with the anisotropic fluid in this case. Restore saturated volume, then think about the sodium later. Then regarding the issue of the rate, I think we don't really know the rate because of the fact that now we know from this. I think I'm just going to share this link for the future. For guys to go and look up. So this guys did a study that was published in this journal, Clinical Journal of Nephrology, 2019, by Johan and his team, they're really looking at the risk of patients developing brain edema or ODS from overcorrection of sodium. And it appears it may not make a big difference, really. So what would happen before is that if you calculated the sodium reduction of, say, 10 millimoles, and you found that the patient overcorrected, you now struggle to give back some sodium to the patient just so that you avoid the risk of cerebral contaminolitis and so on. But this study basically tells us that maybe it is really not necessary to do anymore. So yeah, thank you very, very much for this. This is the end of our talk today. And it looks like we have 10 minutes to spare for the day. And I don't know first if there are any urgent questions from the audience. Okay, so I don't see any hands raised. Neither do I see any questions coming up in the chat. So thank you so much for your audience. At least today we're happy to take you home before 8. Next week we shall communicate next week's problem. That problem is going to be around aspects of brain death and brain death declaration. So I would like to again welcome you guys in your big numbers to join us so that we discuss it. Again, for people interested in presenting, you are welcome to my inbox to let me know that you want to present. However, I know that the residents appear to be having exams next week. So if you don't come up, I will not hold it against you. But overall, thank you so much for your participation. And I think on the chat, Dr. Cornelius is giving us guidance on how to access the recording of this talk. So yeah, maybe just a quick correction from you. When we were calculating the free water losses, we calculated 3.5, supposed to be 4.5, but I'll put that in the chat. So for those interested in that calculation, kindly just copy it off the chat and save it somewhere, then you can study it and maybe apply it in your daily patient care. However, like someone pointed out, there are some calculators on your phone that you can use for this. But the reality I find is that if you don't understand what the calculator is doing and which formula they're using, you'll never understand how they arrive at what they do. So if some things don't work out well, you definitely could get confused. So thank you, Dr. Cornelius, for moderating. Thank you to the panelists, the fellows participating, and to the audience. I wish you a great weekend. Bye-bye.